Okay, so in this video we're going to talk about Chapter 19 on blood vessels, and we'll get into some blood pressure regulation as well. So for the blood vessels of our body, it's a subcategory of the cardiovascular system. We think about blood vessels as being organs because they have at least two tissue types. They have these layers which are made of different tissues. So technically blood vessels are little organs, but they work in conjunction with your heart, which is another organ, to form the organ system, which is your cardiovascular system. Really, the function of your cardiovascular system here, guys, is to really, deliver nutrients out your body and pick up wastes as well. This is done through blood flow. And so we have three major types of vessels throughout our body. We have arteries, capillaries, and veins. Now, the truest definition of an artery is that it carries blood away from the heart. So maybe at some point we've learned that arteries carry oxygenated blood, but we know that we already know that that's not always true because we already learned how the pulmonary arteries carry deoxygenated blood to the lungs, right? So the best example, or the best definition rather, of an artery is a vessel that carries blood away from the heart, right? And because it's carrying blood away from the heart, it's also going to have higher pressure because the heart is what's generating that pressure, right? So if it's a vessel that's carrying blood away from the heart, where the pressure is starting, that means that this vessel is going to have some of the highest blood pressure in your body. So we say that arteries also have thicker walls because they have higher pressures to kind of accommodate there. Now, the truest definition of a vein is that it carries blood back to the heart. And although this is generally true that it carries deoxygenated blood, we already know of some examples of veins in the body that carry oxygenated blood, like the pulmonary veins carry oxygenated blood back to the heart. So the truest definition of a vein, you guys, is that it carries blood towards the heart, right? Now, if it's carrying blood to the heart, that means it's pretty far from where the pressure started because we went full circle, and now we're back towards the heart. So that veins carry fairly low pressure and therefore have fairly thin walls too because they don't have to, kind of compensate for that high pressure. Now, what you find in between veins and arteries, for the most part, are capillaries. Now, capillaries, I like to say, like where the magic happens because they're so thin that nutrients and waste can get exchanged across the wall of this particular vessel. So capillaries are extremely small. They're only about the diameter of one red blood cell. Like they're basically as wide as a red blood cell can squeeze through. And then their walls are so thin that nutrients can diffuse across and waste can diffuse across as well. And that's not true of arteries and veins. Arteries and veins, you don't find nutrient or waste exchange there because the walls are too thick. So what this would look like then, you guys, on this picture here shows an artery and a vein. And we can tell an artery and vein not based on the color because remember, red and with our anatomy and physiology books means oxygenated blood. But do all arteries carry oxygenated blood? No, because you can have a blue artery here too as well. And then we look on the other side here and we say, well, this is a vein, and it's not because it's blue. There's other things we're going to look for, right? So, for instance, veins can carry oxygenated blood, like the pulmonary veins. But the way you can tell artery versus vein, other than the fact that this is labeled, you see the artery label right there, is the fact that arteries have thicker walls, right? So look how thick the wall of this vessel is right here, you guys. And that makes sense because arteries carry high pressure because they're carrying blood away from the heart where the pressure started or was generated. And then veins have thinner walls, and they also have valves too. So if you see a valve in a vessel, it's either a vein or a lymphatic vessel. But here we're talking about blood vessels, so we can assume that it's a vein. And so the function of these valves, like in the lymphatic vessels we talked about earlier, was that they prevent backflow of blood. And it makes sense because veins are a low pressure system, so it prevents blood from pooling in your legs. That way the blood can actually work its way up eventually towards the heart through your skeletal muscle pump and your respiratory pump. So what you find too between veins and arteries, veins and arteries this way, is that the lumen of an artery is typically smaller with respect to the thickness of the wall. And in the vein, the lumen is pretty large with respect to the thickness of the wall. So for instance, veins have larger lumens. And so if the lumen or space of a vein is larger, that also kind of lends to the idea that most of the blood in your body is actually in veins because there's just more space in veins. Like there's more area for blood to be in a vein than an artery because veins have larger lumens. So it's something like 60 or to 70% of your blood is actually in your veins, whereas the rest is going to be in the arteries of your body, which is kind of interesting. And we'll talk about why that is later. So if arteries lead up to a capillary bed and then capillary beds converge into veins, well, let's talk about what these capillary beds are structured like. So The vessel that precedes a capillary bed, you guys, is called an arteriole. And then what goes through the center of the capillary bed is called a meta-arteriole. So this whole center kind of vessel here is called a meta-arteriole. But you can have all these little side channels coming off. So these little side channels coming off are the capillary beds. And it's basically a kind of a wide network of very small vessels, which you can see the structure of right here. So if you look at the structure of a capillary, they have very thin walls. In fact, if you look at this, basically it's one layer of simple squamous cells with an underlying basement membrane. That's it. So it's super thin. And by being so thin, it allows for gases to diffuse across. Water can move across back and forth as well. So can wastes. So and it's just as wide as a red blood cell. So they're very, very small. And then those capillaries will reconverge back into a venule, which then will reconverge into the larger veins of your body. Okay. So if we can look on this slide here, we'll be doing this a little bit of this in lab as well, identifying the difference between an artery versus a vein. So if you guys remember, like, what are we going to look for an artery versus a vein? If you look, other than the fact that this is labeled, right? The what's that? Yeah, the thickness of the wall. Which one has thicker walls? The arteries, right? So this is pretty obviously an artery because look how thick that wall is, you guys. This is like super, super thick here, right? And then if this is our vein, look how thin that wall is. But it's always in respect to the lumen, right? So look how big this lumen is here, and look how small this lumen is here. So you can tell, okay, this wall is thick with a small lumen. It's probably an artery, right? And this wall is thin with a large lumen. It's probably a vein. In fact, you actually can see red blood cells in this vessel right here, you guys. All these are little red blood cells that are still in the vessel lumen, which is kind of interesting. Okay, cool. So for the different types of arteries of our body, you guys, we have elastic arteries, muscular arteries, and arterioles. And so it's basically in descending order of size. So the largest arteries of your body are these elastic arteries, and that would include things like your aorta, your brachiocephalic trunk, your left common carotid, left subclavian, and subclavian arteries, right side too. So those are elastic arteries. And elastic arteries, as the name implies, have some elasticity to them, right? So what happens is when your heart contracts and you're in systole and blood's being forced out of the heart into the aorta, what happens is the aorta can stretch and accommodate that blood, okay? Then when the heart relaxes, that elastic artery can actually slowly start to relax back down to a resting shape, right? But what this does is it actually generates some pressure. So if y'all remember, we said that we had systolic versus diastolic phases of a heart. Now we'll talk about systolic versus diastolic pressures here too today. And we'll learn as well that diastolic pressure is due to sometimes, not all of it, but some of that diastolic pressure is due to the fact that you have elastic arteries. So even though your heart's not currently contracting, the elastic arteries stretched while the heart was contracting, and then they slowly relax back down to a resting shape. But as they're relaxing, they're generating pressure, right? It's kind of like a rubber band. Like once you stretch that rubber band, you can slowly release it. And as you release it, you're kind of like releasing some energy there, if that makes sense. Just like as these arteries were stretched, as they relax back to resting shape, that's keeping your pressure higher, which keeps your diastolic pressure up, right? And we'll learn about why that's important later. But think about this, you guys. The elastic arteries are involved with accommodating stretch from blood flow from your heart and maintaining diastolic pressure. Because when they relax, they can generate some pressure, okay? So we also have these muscular arteries. And these muscular arteries are smaller than elastic arteries. These are going to be examples of like some of the smaller arteries of your body, like branches of the elastic arteries. Things like your like radial arteries and ulnar arteries and branches of those, okay? So these muscular arteries are called that because they have a thicker tunica media versus other layers. And so the tunica media is a muscular layer of the vessel wall. And so by having this thicker tunica media, they can help regulate blood flow pretty well throughout the body. And then the last artery we have here, you guys, is called the arteriole. If y'all remember, the arteriole is what precedes the capillary bed. And it turns out, you guys, that the arterioles of your body have the biggest effect on blood flow and blood pressure than any other vessel, right? So if you're talking about maintaining blood flow and blood pressure, it's really maintained at the level of your body's arterioles, because these outnumber muscular arteries and elastic arteries by a lot, right? And they help regulate blood flow into and out of capillary beds, or just into capillary beds, rather. And so, they can actually alter where blood's going. Now, if you look at these arterioles, they're much smaller. Not necessarily, well, these aren't drawn to scale. That's important to note, by the way. Obviously this elastic artery is going to be like 100 times bigger than like an arteriole. You know what I mean? But if you look at the thickness of the wall, our arterioles don't have that many layers. You have a simple squamous endothelium on the inside. There's some connective tissue here, and then we have these smooth muscle cells that wrap around the outside of the vessel. Now, the function of these smooth muscle cells here on the outside of the arteriole is to basically help change the diameter of the arteriole. That way you can regulate blood flow and blood pressure. But we'll talk about how that works later today too, like how blood flow and blood pressure are regulated at the level of arterioles. So remember, arterioles are what precede capillaries. And capillaries, like I said, you guys, that's where the magic happens, right? Because this is where the vessel walls are thin, and that allows for nutrients and wastes to be exchanged across that thin vessel wall. Now, the pressure inside these capillaries is pretty low. Like we're saying, it's probably around 15 or 20 millimeters of mercury, right? Whereas your systolic pressure of your heart can be like 120 or so. Okay, so capillary pressure is fairly low, but it's still high enough for things to get forced out into the tissue. And we'll talk about that, not today, but in the next video or next lecture. So, but there are 3 types of capillaries, and they're classified on the degree of leakiness. Because we know that capillaries aren't like waterproof, because if they were, we wouldn't even need our lymphatic system, right? So remember we said that we have a lymphatic system which picks up excess fluid from our tissues and then carries that back into the bloodstream. Well, we said that fluid, which was excess interstitial fluid, came from blood plasma. And the way that blood plasma gets into your tissues is through a variety of forces we'll talk about later, but one of the major forces is blood pressure. So kind of like a hose with lots of holes in it. Once you turn that hose on, it's going to start squirting water out of the hose and just spraying out, away from the hose. Kind of like these capillaries, you guys. So some of these capillaries can actually leak water. They kind of spray water into the surrounding tissue, you might say, And so they're classified based on the degree of leakiness. So the continuous capillaries are the least leaky, and the sinusoidal capillaries are the most leaky. And we'll talk about where they're found and why that's important. So the continuous capillaries are abundant in skin and muscles. They have lots of tight junctions, which allow for waterproofing. And there are some intercellular clefts that allow for fluid to pass between these cells. But basically the functions of these continuous capillaries, you guys, is that they're really good at waterproofing, and you don't have as much water leaving your plasma and entering those tissues. So this is particularly important in the brain, where we have our blood-brain barrier. Like you wouldn't want a lot of water from the vessels of your brain leaking into your brain tissue, because if your brain's started to swell, it's swelling within a restrictive space. So what we have then are these tight junctions which hold these cells together very strongly. That way water can't pass from blood into your brain tissue. So continuous capillaries help form the blood-brain barrier. If you guys remember that, going back to AP1. So remember, the blood-brain barrier also prevents wastes that are in your blood from getting into your brain tissue, and things that are potentially toxic from damaging your brain tissue. So continuous capillaries help make that up. So what does this look like? Well, these are the cells that line the inside of the blood vessel itself, and we call these endothelial cells. And these endothelial cells are basically a simple squamous, you might say, an epithelium, right? But we call it endothelium here because it's inside your blood vessels. So if it's simple squamous, we're saying it's one layer of flattened cells. And you guys can see that here, right? Like here's a nucleus, and there's only one cell layer here. This is where the cells are bound together with tight junctions and that kind of stuff. Now, if you have an epithelium, we said that there has to be an underlying basement membrane. That's what we see here. But the basement membrane of these continuous capillaries is complete. Like there's no holes in the basement membrane. If you guys remember going back to AP1, we said that basement membranes are structured a lot like a coffee filter, where it's just basically a lot of fibers that are intertwined, right? And even the function of these basement membranes functions like a filter too. That way, things can't just leave your bloodstream and enter the tissue, or vice versa, because there's actually a fibrous basement membrane kind of in the way, and so it functions like a filter in that regard. But one of its major functions, you guys, is just to serve as a scaffolding for these cells to attach to, okay? But by having these cells held together strongly with tight junctions, and having a complete basement membrane, as well as some of these pericytes, which can actually add an extra layer of support, that makes these continuous capillaries. So how leaky are these? Not leaky, right? They can leak a little bit of water, but not that much. So where are these found in the body? You guys remember? The blood-brain barrier, very good, awesome. Also, skin and muscles are really abundant with continuous capillaries. Okay, good. Okay, guys. So what we find then the next one are these fenestrated capillaries. So what looks different to you all about the fenestrated capillaries versus the continuous? So here's continuous. Here's fenestration. There's kind of pores, exactly. So in fact, those pores we actually call the fenestrations themselves. So a fenestrated capillary has lots of pores or holes, in the cell itself. So what these would be like is kind of like a little hole in the cell, but it's not as though it's like opening up into the inside of the cell. It's just like a place where the cell membrane kind of forms like a tube, if that makes sense. And so by having a little hole, that allows for fluid to be able to slip through those cells back and forth. And we call those fenestrations. Now, here's a red blood cell right here, right? It's in the vessel, just kind of drawn to scale. This red blood cell can't pass through the fenestrations because those fenestrations are too small. So what do you guys think could pass through those fenestrations or holes? Not cells, but what could potentially pass through? Water, glucose, very good. Other small wastes, right? Maybe even some small proteins. Even ions like sodium, potassium, calcium, that kind of stuff. And maybe even potentially platelets, it depends. But these fenestrations, though, make these capillaries much more leaky. And to me, this kind of looks like those old school hoses. Maybe not old school. Some people still use this stuff, you know what I mean? But you guys ever seen that where it's like a soaker hose? Where it's like that black hose with all those it's like a million little holes in it. And once you turn it on, it starts spraying water everywhere. And I remember doing this when I was a kid because we have a sprinkler system. So I'd go outside, I'd have to keep moving the hose, If it's been 20 minutes, my dad would be like, go move the hose. And I have to go move the hose because you have to have it spray in the next area of grass or whatever. To me, that's what this looks like, you guys. It's like the hose with lots of little holes. And so it's going to spray water out in the tissue. Now, this is important, though, in some places in your body. Like for one place you'd want these fenestrated capillaries, your kidneys. Because think of this as like a filter, you guys. If you want to be able to filter your blood, where essentially you want to have water spray out of the bloodstream but not lose cells, then these fenestrated capillaries would be a great place to do that. And so you find this in places like your kidneys, where you want a lot of filtration, and also the small intestine, where you need to have rapid absorption as well. So we'll come back to these fenestrated capillaries when we talk about kidney filtration mechanisms later as well. So what looks different about these ones? The sinusoidal capillaries. Very good. First of all, there's an incomplete basement membrane. You guys see that? Like the basement membrane isn't all connected here, which means there's gaps in the places where there should be fibers. Good. What else? Yeah, very good. There's big intercellular clefts, which we can see here. In fact, these aren't even fenestrations at this point. Very good. We call them intercellular clefts. And a cleft is just like a large space. Like you guys heard of cleft palate before, where someone's oral cavity can open up in the nasal cavity. So you get a cleft there. Well, think about having a large cleft between your between your blood vessel cells, right? The endothelial cells. And so what happens with these fenestrated capillaries, I'm not fenestrated, sinusoidal. These sinusoidal capillaries are actually able to pass entire cells across the vessel wall. And you find these in places where you want cells to go into and out of bloodstream really easily. So one example of this is red bone marrow. So how would it make sense to have these ones in red bone marrow? Or just bone marrow in general? What's the function of red bone marrow? Creates red blood cells. So how do you guys think that red blood cells actually get into the bloodstream? It's these things here. Because once those red blood cells are created, they can squeeze in through those intercellular clefts and enter the bloodstream that way. Cool. So how would it make sense to find these in the spleen as well, or the liver, knowing about the circulation and life cycle of red blood cells? Yeah, it's really recycled, right? So what does a spleen do to red blood cells? It can store them. Good. So to store them, you got to take them out of the bloodstream anyways. So to store those, you got to have red blood cells be able to leave that and enter like a space within the spleen. So to leave the bloodstream, you have to have like large spaces there. Good. But the spleen also breaks down those red blood cells, right? So that in order to break these down too, the ones that are damaged and could leave then are actually ingested or sort of engulfed rather by macrophages called Kupffer cells that are in there. Okay, cool. Good job, you guys. So actually, just to review that, what are the three types of capillaries? So we have, which one's the least leaky? Continuous. Second to that, fenestrated, and then the most leaky, sinusoidal. Good. Which one do you find in bone marrow? Sinusoidal. Good. Which one would make sense to make up the blood-brain barrier? Continuous. Exactly. Very good. Cool. So those would be like example style exam questions. You know what I mean? Like, which of these do you find in the kidneys for filtration? And you guys would say fenestrated. Yeah, fenestrated, because they're not going to allow cells to pass through, because you don't want to be peeing out red blood cells, right? But they will allow water with wastes to pass through. That's why the fenestrations are just large enough for that to happen. Okay, go. All right, guys, so let's look at the structure of the capillary bed here. So we said that arteries can lead into arterioles, and so the arteriole is what leads into the capillary bed. So right here is our last arteriole before it leads into what's called the meta-arteriole. And the meta-arteriole is what passes through the capillary bed, and it turns into what's called a thoroughfare channel, which then converges into a venule, which then turns into veins, right? So this central vessel here, you guys, always has at least some flow, okay? Now, what your capillary beds can do, though, is modulate blood flow at the level of these side channels here. You guys see these? So there's all these little side channels coming off, and where every side channel comes off of the meta-arteriole or thoroughfare channel, you're going to find these precapillary sphincters, right? Now, the precapillary sphincters are little rings of smooth muscle cells that can change the diameter of those capillaries, okay? So let's say if you wanted to have blood flow through a capillary bed, you would relax these precapillary sphincters, and then blood can kind of, go out those little side channels, and you might say kind of floods the field, Like, to me, this kind of looks like a, like farming aqueduct system, where you might have like a main aqueduct going through your town, like your farming town, and that aqueduct maybe comes off the Platte River or something, right? And then what happens is that each farm that's along the aqueduct has their own little valve, and if they want to flood their fields, what they do is they just turn a wheel, opens up the floodgate, and then the water can come off the channel and go out into their field, right? And so your body has something like that here with this capillary bed, except for these precapillary sphincters can either be constricted to reduce blood flow, or they can dilate to increase blood flow. And so down here shows the condition where if these precapillary sphincters are constricted, then you have less blood flowing through these capillary beds. Okay. Up top, this shows where the precapillary sphincters are relaxed, then you have more blood flowing through the capillary beds. And you might wonder, well, why would you ever want to have more or less blood flow flowing through a capillary? Well, we've actually talked about this a little bit already with respect to your autonomic nervous system. Because if y'all remember, we said with the autonomic nervous system, you can increase or decrease blood flow to tissues based on what your body needs. So like during exercise, where would you want to increase blood flow to? Muscles, for sure, right? But where do you decrease blood flow to during exercise? Digestive system, good. So for instance, like this could be like the capillary beds of your digestive tract while you're exercising, where you want to reduce blood flow into those organs. And this could be the capillary beds of your muscles while you're, exercising. That way you can increase blood flow into those muscles, which makes sense. Now, these precapillary sphincters are under the control of hormones in your nervous system. So we'll come back to this later, I think at some point. But we'll say that certain hormones, and as well as your nervous system, can actually, modulate blood flow across the capillary beds of your body. Now, what's important to note, though, you guys, is that you always have at least some blood flow going through it, though. Because you guys notice that there's no sphincter here, right? Which means you're always going to have at least some blood flowing through the meta-arteriole and thoroughfare channel. But what you can do, though, is kind of open up the floodgates on the side and allow more blood to flow through that capillary. Awesome. Make sense, you guys? Okay. So with veins, you guys, we say that veins are formed when venules converge. And so they have thinner walls. Why do veins have thinner walls? You guys remember? Yeah, there's less pressure. Exactly. Good. So if veins have less pressure, they can get away with having thinner walls. Good. And their tunica media is there, which is a smooth muscle layer, but it's kind of thin, if that makes sense, because they're not involved so much with changing your vessel diameter. There's still a tunica externa of collagen fibers and some elastic fibers, but we call veins capacitance vessels. And the reason why we call them capacitance vessels is that a capacitor stores something, right? So veins are capacitance vessels because they store the blood of your body. Like at any moment in time, you can have something close to 65% of your blood just in your veins, right? Now the rest would be like in the capillary beds or your arteries, but we say that veins store the majority of your body's blood, okay? That's important to know. So basically they kind of act as a reservoir of blood. So if we look at where the blood's at in your body at any moment in time, we have systemic veins and venules, which can store like 60% here. That's what this slide is showing. Your systemic arteries and arterioles only carry 15% of your blood. So if you think about it, remember like we did the vessel model, you guys, and we drew all those arteries. Remember like the descending aorta, the celi trunk, superior and inferior mesenteric arteries, and then even like the common iliacs and all those branches. And it seemed like, man, that's a lot of arteries. What's weird though is that still only holds 15% of your blood. And so don't think about that vessel model that we saw. Even the models we have in lab is actually being to scale because you have way more veins of your body than you do have arteries. Okay, even though we didn't go over that many veins in lab, if that makes sense. So, but these veins store a lot of blood, 60% of your blood. Only 15% of your blood's in arteries at any moment. Okay. Now, pulmonary blood vessels can carry about 12%. Your heart holds 8%. And I'm not saying like the muscle. I'm not saying that the blood that's in the muscle tissue. I'm saying that blood that's in the heart chambers ends up being about 8% of your blood volume, okay? And then we have blood in capillaries, which is only 5%. Now, do you guys think this can change, though? Absolutely, right. So what happens during exercise is that you can get venoconstriction, and you can push some of the 60% into any of these categories. So during exercise, you want to take blood out of your veins and get that into your lungs, or get that into your heart. Get that in the capillaries of your body and the arteries of your body. So this pie chart can vary based on what you're doing. During rest, this is kind of more like on the rest side. But during exercise, you're actually going to kind of shift the blood away from the venous end and get that into the rest of the vessels. But that's done through a process called venoconstriction. So veins can constrict using their tunica media. And when they constrict, they can force that blood back to your heart faster. And then your heart can distribute that blood out to the rest of those vessels. But when your veins stay constricted, they can't store as much blood. But we'll come back to that. Keep that in mind. Okay. All right, guys. So veins, if they carry low pressure, it also makes sense for them to have valves. So we said that veins have these one-way valves, just like lymphatic vessels do, to prevent backflow. And it turns out that venous blood is drawn up towards the heart, pretty much using the same mechanisms as lymphatic flow. So if you guys remember, we said that you have a respiratory pump and a skeletal muscle pump to help draw lymph back up towards your heart, right? It's the same thing for venous blood too. Like if you take a deep breath, it draws venous blood up to your heart. If you start squeezing on muscles of your legs or your limbs, just squeezing your muscles, it's going to force that blood back to your heart even faster. The difference here, though, you guys, is that we don't have peristalsis in veins like we do with lymphatic vessels. There's no like undulatory motions of veins, but veins can constrict. So they can like constrict and squeeze blood up to the heart. And veins also have valves, just like lymphatic vessels. So the valves prevent backflow of blood, back towards the feet or something. Now, when these valves fail, that can lead to things like varicose veins or varicosities. And we'll talk about that later in pathophysiology. But, kind of keep that in mind. Now, we also have venous sinuses. And a venous sinus is basically where blood can kind of pool in a large area. One example of a venous sinus we've already talked about was the coronary sinus of your heart. Because remember, if we looked in the back of the heart, we saw the coronary sinus there. That was a place where all the coronary venous blood, or cardiac veins, converge before it drains back into the right atrium. But it's just a place to store blood, if that makes sense. Some other sinuses we've talked about, you guys, were the dural venous sinuses of your skull. So if you guys remember the meninges of your skull, there's places where the dura mater can separate, and it forms these blood-filled spaces, around your brain. And that's basically where all the veins of your brain drain into. And then all the dural venous sinuses come together and they converge to form the jugular veins, which then drain blood towards your heart. Okay? So those are some examples of venous sinuses in the body. Okay. So looking at the veins in the body, guys, we have venules here and then veins. Here's our capillary. So again, they're only one cell layer thick. Venules are structured a lot like arterioles. Again, because you have one cell layer on the inside, a little bit of connective tissue that supports that, and then they're also surrounded by some smooth muscle cells around that. Now, the structure of a vein is almost identical to the structure of an artery, other than the fact that the lumens are larger and the walls are thinner, right? But if you think about like the number of layers here, it's all the same layers. So you still have a tunica intima, which is making the inside, which is that's your simple squamous epithelium. You'll still have a tunica media, which is the smooth muscle layer in the middle, and you still have a tunica externa, which is the outer kind of fibrous tissue on the outside of that vessel. Now, some of your larger veins also have elastic tissue in them as well. So you're going to have things like an internal elastic lamina. Now, elastic arteries have an extra elastic layer called the external elastic lamina. So what's also kind of interesting too, guys, just another concept, are these ideas of anastomoses. And we've mentioned this already in lab because we said that your heart is full of anastomosis. That's basically where these arteries can connect with each other. So normally we say that arteries connect with veins, and there's a capillary bed in between. But there are circumstances throughout your body, they're all over, where arteries can connect directly with another artery. And the significance of these anastomoses is that it allows for blood flow to a tissue and ensures the blood's actually going to get there. Because imagine if like one of those arteries were cut off, like you get a blockage, or if the pressure was low in one artery, it's at least you still have another artery coming around the other way to help supply blood. And so basically these anastomoses are like backup plans, or kind of redundant pathways for blood flow through an organ or tissue. And they're all over the place, by the way. You can also have venous anastomoses as well. So an example of a venous anastomosis are the ones in your liver, where the hepatic portal vein, when it all converges and goes in your liver, that branches out into venous anastomoses, which your liver uses to process that blood. Okay, but think about arterial anastomoses, you guys, just backup plan for blood flow. Okay, they're all over. Like they're common in your joints, abdominal organs, brain, and your heart. If these get malformed, that can lead to things like hemorrhagic stroke. So if you guys heard of like things like AV malformations, right? So arteriovenous malformations, that's in a type of anastomosis that is weak and it can potentially rupture, which means you can have a bleed somewhere like in your brain. And it's particularly dangerous in the brain because your brain can't expand within the skull. So if you do have bleeding within the brain, it's going to lead to some problems. All right, guys, cool. So now we're going to move on to talk about some concepts like blood flow. So blood flow, if you just think about like what this means, blood flow is just a measure of the movement of blood through a vessel per a unit time. So example of blood flow we gave already, guys, was cardiac output from the heart. So if you guys remember, the equation for cardiac output, or CO, was stroke volume times heart rate. And so cardiac output was blood flow through the heart in 1 minute. And if you guys remember, it was in mils per minute. Or you could say liters per minute, too, if you want to round up. So we said stroke volume was blood per beat. So milliliters of blood per heartbeat. And then heart rate was beats per minute. And then what happens, you guys, is that the beats cancel out, so you end up with mils per minute. And that's cardiac output, which is really just the same as blood flow. So if you're talking about blood flow through your body, guys, it's exactly the same thing as cardiac output because that's what's actually pumping the blood, right? So it's measured in mils per minute. It's relatively constant while you're at rest. Do you guys remember what was your cardiac output at rest? Like how much blood does your heart pump out in 1 minute at rest? You guys remember? How many of these things? 5, right? Good. So 5 liters. So, or it could be a little bit more too. It could be a little bit less. Depends on your size of your body. But your heart can pump out 5 or 6 liters per minute at rest. What was the peak cardiac output? You guys remember? Like in a trained athlete? 35, which is tremendous, right? So your cardiac output or blood flow could be super high during exercise. So again, it's just going to vary depending on the needs of your body. So during exercise, obviously your body needs a lot more blood flow, a lot more nutrients, and to pick up waste faster. So blood flow needs to be faster. So what happens then, you guys, is your heart is tasked with the challenge of ensuring that blood flow matches metabolism. If there's a mismatch of those two, then you get problems, okay? So technically, heart failure, you guys, to define what heart failure means, heart failure is where your cardiac output cannot meet your body's metabolic needs. So if your metabolism is faster than what your heart can keep up with, that's what heart failure is. Okay? So if your heart can't ensure adequate blood flow, then we're saying that it's failing. And we'll talk about different types of heart failure in pathophysiology. Okay, cool. All right, guys, so what about blood pressure? Well, blood pressure is a force per unit area that's exerted on the blood vessel wall. So with blood pressure, you guys, it's basically a compressible fluid, right? So blood gets compressed. So we're saying that when your heart contracts, it compresses that blood into a smaller area. And then that blood gets forced out into a vessel. But because it's compressed, it wants to expand back outward, right, from its compressed state. But as it tries to expand outward, it's actually forcing on the vessel walls, and it's causing those vessel walls to get stretched a little bit, right? So blood pressure, as we measure it, is the force that blood exerts on the blood vessels due to its compression, okay? And that's if you're measuring it externally, like with a blood pressure cuff, right? Is you're measuring how much force does it take to push that blood vessel open, okay? All right, so resistance is the opposition to flow, and we're saying then if you have high resistance, there's less flow. We've actually talked about this already going back to airflow. So if you guys remember, with airflow, we said that the flow of air flow was 1 over the resistance. If you guys remember that one? So we said that you get more airflow when your resistance is lower. And so what was one of the major factors of airway resistance we talked about? You guys remember? Say it again. Lung compliance is one of them, good. But what's the one that can change really quickly? Yeah, good. Bronchoconstriction or bronchodilation. So what happens to resistance when you bronchoconstrict? Increases, good. And by the way, you guys, it's the same exact thing for blood vessels, which is awesome. So you guys have already learned this, right? Just using different words. So we say that if you vasoconstrict, you increase resistance, and what does that do to flow? It decreases flow. So if you increase resistance, you decrease flow. Can you guys see that? Okay, cool. So, all right, awesome, very good. And do you guys remember the equation for blood pressure? Did we talk about that or no? Okay, so the equation for blood pressure, guys, blood pressure is equal to cardiac output times total peripheral resistance. Okay? So we'll come back to that too. I'm just going to write this on the board for now, but we'll come back to that. Okay? But do you guys see that on the slide? It says there are 3 things that affect resistance. We've already given one. So what was the one we just talked about? Blood vessel diameter. Good, exactly. So you can change your blood vessel diameter because your tunica media can change diameter, right? So what we're saying here then, you guys, is that if you change your blood vessel diameter, you can change your resistance, which changes flow. If you change your flow, you can also change things like cardiac output, so delivery to blood to tissues. Now, there are 2 other factors that affect resistance, you guys, and these ones are kind of weird. They don't change rapidly, but they are important to consider just with respect to the human body and knowing how blood pressure works. So, blood viscosity. So viscosity is a resistance to flow, right? Actually, I think that's on the next slide here. So blood viscosity is this resistance to flow. It's like the stickiness of blood. So we know that blood is mostly water, but what's the other 45% of blood made of? Red blood cells, good. And do you guys remember we talked about this with blood doping and stuff? What happens if you have way more hematocrit? Instead of being 45%, what if your hematocrit was 55% or 60%? What happens to your blood? More viscous, more sticky. Exactly, good. So if it's more viscous or more sticky, we're saying it's more resistant to flow because viscosity is actually a measure of the resistance to flow, right? So if it's more viscous because of less plasma and more red blood cells, you have higher resistance, what happens to blood flow? Decreases. You got it. Very good. This is why we can't have too many red blood cells. If we did, our blood would be too thick to pump, and it would put a lot of pressure in our heart, or a lot of, it would put a lot of stress on your heart rather to try to overcome that resistance. Okay. So the next one too, guys, is blood vessel length. So if you have longer blood vessels, there's more resistance. Shorter blood vessels, less resistance, right? So what does this tell us then if someone has a missing limb, where the blood vessels are shorter because they don't have the rest of their arm on this side, and the blood vessels are longer because they have blood vessels still in their remaining limb? Would you think the blood pressure is going to be the same between the right and left arms? Nope. You're going to get different blood pressures. That's very important to consider. So if you try to measure someone's blood pressure on a limb where they have a prosthetic, you're going to get a different systemic blood pressure than you would with the other limb. Okay. So you got to measure one or both to figure out what's really going on. Okay. All right. What does that mean for tall people too? Let's say if you're really tall and you got big old long vessels. More resistance, more stress on your heart. So this is actually one of the reasons why tall people typically don't live that long. You know what I mean? Like it's really rare to find like a 120-year-old 6'3" person. You know what I mean? Those guys usually die of heart failure or something before that. You know, you're more likely to find the little bitty itty 120-year-olds because their hearts can keep up with that long. Like they don't have long vessels to try to pump against for 120 years, right? So, or however long they've been that tall. So the next one, you guys, is blood vessel diameter. Now, this is the one that's really important to consider with respect to kind of rapid changes in resistance and blood pressure. Okay. So here's the interesting thing, you guys. Not only does it have the greatest influence on resistance, but it also is the most quick to change. And it can change so quickly, your blood pressure can spike or drop out in a matter of fractions of a second. Okay? So the way we calculate this, you guys, is that in terms of resistance for blood vessel diameter, we say that resistance, or big R, is equal to the inverse, right, or 1 over the radius to the power of 4. So we're saying that blood vessel radius is inversely proportional to resistance. So what does that mean if you increase the radius of a blood vessel? What happens to resistance? If you increase radius, what happens to resistance? It decreases resistance. Good. Now you can also just say diameter. That's fine too. You know what I mean? So this equation uses radius as your example. You could say blood vessel diameter. It doesn't matter. Whatever. It's pretty much the same thing. Okay. So if you increase the radius by vasodilating, what happens to resistance? Decreases resistance. What happens to flow? You increase flow. Very good. Okay. So, but do you guys notice that this is to the power of 4? So we're saying that any changes in radius are amplified to the power of 4. So what does that mean for very small changes in blood vessel radius? What does that lead to? Large changes in resistance, right? It makes sense because all you have to do is change that radius number by a small bit. But since it's to the power of 4, very small changes are amplified, right? So if you change your blood vessel radius just a little bit, you have big changes in resistance. Whether it's an increase or a decrease depends on which way it's going. So I ask you guys this. What if you have a patient that has super low blood pressure? What would you want to do to their blood vessels to help get their blood pressure up? Would you want to constrict or dilate? Actually, we haven't talked about blood pressure yet. Just kidding. Let's come back to that question. Our blood pressure equation's up here, but let's come back to that, okay? Just kidding. All right, guys. So with blood flow, we're saying it's proportional to pressure gradient. And we've also already used this example of an equation too. You guys remember with airflow, we said another way to write airflow was delta P over R. And we said you have to have a pressure gradient, and there's some resistance there to get flow to happen. So we say that if your delta P increases, or pressure differential, remember blood and air only flow from high pressure to low pressure. So that's what delta P is. It's a difference in pressure, right? So if you have a larger difference in pressure, blood's going to flow faster, right? Or if you increase resistance, blood's going to flow more slowly because it's the inverse of flow. Okay? Cool. So that's what this equation here is showing. So to get more flow, you either need a larger pressure gradient or less resistance. Okay? All right, guys, cool. So checking this equation, looking at this graph here, we see our blood pressure in millimeters of mercury, as well as the major vessels of our body on this side here. So we have our aorta, our arteries, arterioles, capillaries, venules, veins, and vena cava. So it's basically going from your large arteries down to capillary beds and then back again. So then vena cava would drain blood back into what should be over here. So where did the vena cava drain blood into? The right atrium. Good. I was kind of just looking for the heart, but I like that you guys got specific. That's good. So the heart, right? And then what about over here? The heart then would pump blood into the aorta. So what's kind of missing from this graph then is the heart, but the heart would be in between both sides, right? Because it goes full circle. All right, cool. So let's just start on this side, you guys. At the level of your aorta, do you guys see that there's two pressures here? We have a pressure up top and a pressure down below. The pressure that's up top is your systolic pressure. And systolic pressure is the pressure that's generated while you're in ventricular systole. And then down here is called diastolic pressure. That's the pressure that's generated while you're in ventricular diastole, or rest. Okay? Which one do you spend more time in? Diastole or systole? Diastole, good. In fact, you spend 2/3 of the time in diastole and only 1/3 of the time in systole. In fact, you guys see that there's this little line in the center here? This is showing what's called mean arterial pressure, or MAP. But does this line in the center look like it's really in the center of these two lines? No, it's not. It's not right in the center. And the reason why it's not in the center is that the average of these pressures is not dead center. The average of these centers is actually closer to your diastolic pressure because they're weighted differently. You spend 2/3 of the time in diastole and only 1/3 of the time in systole, which means your average blood pressure is going to be closer to your diastolic pressure than your systolic pressure. Okay? That's what we're seeing here is mean arterial pressure. So mean arterial pressure, the equation for that, you guys, is diastolic pressure plus 1/3 pulse pressure. Pulse pressure is your systolic minus your diastolic. Okay? And the reason why it's 1/3 is that you spend 2/3 of the time in diastole and only 1/3 of the time in systole. Okay? So to get your average pressure, you can use that equation if you want, if you're interested. Okay? So that means that your diastolic pressure is much more relevant and much more important with respect to cardiac health. Because if you're spending more time in diastole, that means your diastolic pressure is what your heart has to overcome with the next beat. So if your diastolic blood pressure is too high, that's going to put a lot of afterload on your heart to try to pump blood out, right? So keep that in mind. But do you guys see how that our blood pressure kind of fluctuates back and forth here? Up and down? Those are our pulses, right? So we see these pulsations continue through your aorta, through your arteries, even through your arterioles. But when do the pulses disappear? Capillaries, right? And so when the pulses disappear at the level of capillaries, now we just have one solid blood pressure. There's no pulses. So you don't find pulses in capillaries. You don't even find pulses in veins. Veins in venules and vena cava, they have one solid blood pressure. There's no pulsation there, right? So if you're feeling a pulse, it's an artery, not a vein. Now veins can pulse under disease states, but we'll come back to that in pathophysiology. But under normal conditions, veins don't pulse, only arteries pulse. But do you guys see how there's this jagged line here, but there's this little blip right there? What's that little blip? Do you guys remember? What was that? No, this is pressure, not EKG. So remember what happens when so blood pressure goes up, and then as the pressure starts to fall, the aortic simulator valve closes. What's that little pressure blip due to the closure of the aortic valve? It's called the dicrotic notch. You guys remember that one? So the dicrotic notch is right there. You can see that. It's actually on the blood pressure here, which makes sense. Remember, the dicrotic notch was that pressure wave that's transmitted across your aorta and other large vessels due to the closure of that the aortic simulator valve. It closes with so much force, it sends out a pressure wave. So you're actually seeing the dicrotic notch right there, which is kind of cool. Okay, cool. So do you guys notice that the general tendency of this pressure is to go from high to low? That kind of makes sense. As you get farther from the heart, pressure starts to go down. And the reason why you lose pressure as you go down, you guys, is there's friction along your blood vessels, and your blood vessels start branching out. And as they branch out, you get more cross-sectional area, which means that there's less pressure. Okay. So remember, flow goes from high pressure to low pressure. And so what can we say about the general tendency of blood flow then if our pressure is higher on the artery end and lower on the vein end? Where does flow go? In this direction. You got it from high to low pressure. So, but you can change flow though, right? Because flow is not only dependent on a pressure gradient, what also influences blood flow. You guys remember going back to our equation? So flow is a pressure gradient divided by resistance. Big R is resistance. So you can change the flow rate based on what your resistance is. So what were the three factors that affect arterial resistance? You guys remember? Vessel diameter or radius, same thing. Viscosity of blood and the length of those blood vessels. Very good. Which was the one that changes rapidly? Diameter. Very good. And that's the one that's under control of hormones, your nervous system, and autoregulatory mechanisms that we'll talk about in the next lecture. Okay. All right, guys, cool. So let's say if we go back to this slide, though. Notice how venous pressure gets pretty dang close to zero. You guys see that? Like by the time you get to vena cava, the pressure that's in those veins is almost 0 millimeters of mercury. Okay. So what that means then is we need something to help draw that blood up to your heart. And the way the venous blood gets back to your heart are basically these three major mechanisms. So you have a muscular pump, a respiratory pump, and you have sympathetic venoconstriction. So if you guys remember, the muscular pump is like a milking action of your muscles on your veins. So basically it can squeeze on those veins and help force blood back up to the heart. And then our respiratory pump is when you breathe, you take a deep breath, it increases thoracic volume, which then decreases thoracic pressure. Because the pressure is lower in your thoracic cage, blood then gets drawn up towards the heart, or where the thorax is, right? And then we also have venoconstriction. So veins can constrict, and by constricting, they can help force that blood up to the heart even faster, right? But when the veins constrict, what prevents the blood from going back down? Valves. Exactly, good. So valves prevent that backflow. So when you have venoconstriction, it only forces the blood in one direction, usually, unless the valves aren't functioning. So if you guys look here, this is showing that milking action of skeletal muscles. So when the veins are by your skeletal muscles and they can kind of squeeze in those veins, it's going to force blood up in a particular direction with the valves, not against them, because the valves prevent backflow. Okay. So it turns out, you guys, that we have three different organ systems that maintain blood pressure in our body. So it actually requires cooperation between your heart, your blood vessels, and your kidneys. Okay. And so the way this works, you guys, is that your heart maintains blood pressure by maintaining cardiac output. Okay? Your kidneys maintain blood pressure by maintaining blood volume. And your blood vessels maintain blood pressure by maintaining a certain amount of resistance. Okay? So, talking about blood pressure, you guys, it's basically a force per unit area, but there's some different ways we can calculate that, right? So we can rearrange our equations up here to kind of get some ideas. Like flow was delta P over R. Cardiac output was also delta P over R. So we say that cardiac output is the same as flow because they both have the same other side of the equation. Or you can also say that delta P, or pressure difference, is cardiac output times resistance. So delta P is your pressure then, right? That's your blood pressure, which is cardiac output times resistance. So one way to write blood pressure then over here, I already drew it on the board here, is blood pressure is cardiac output times total peripheral resistance. Okay, so how can we increase or decrease blood pressure? Let's say if we wanted to increase someone's blood pressure, what can we do for them to help raise their blood pressure based on these two variables? Increase either one, right? Good. So you can increase cardiac output or increase resistance. Okay, good. So how could you increase cardiac output? What was our equation for that? You can increase stroke volume, or you can increase heart rate. In either of those would increase cardiac output, right? How could you increase stroke volume? You guys remember the equation for stroke volume? So stroke volume was EDV minus ESV. So how could you increase stroke volume then? Increase your EDV. What's another word for EDV, or end diastolic volume? It's the same as something else. Venous return. Okay? So end diastolic volume is the same as venous return. So let's think about this, you guys. Venous return. Okay? So if you increase venous return to the heart, you increase end diastolic volume. And by the way, let's think about this. How do you increase venous return to the heart? We just talked about this. So you guys tell me. Respiratory pump? Muscular pump? Or? Venoconstriction. Good. So all three of those would increase end diastolic volume. If you increase end diastolic volume, what does that do to stroke volume? Increases stroke volume. If you increase stroke volume, what does it do to cardiac output? Increases cardiac output. If you increase cardiac output, what does it do to blood pressure? Increases blood pressure. So presumably, what would happen to your blood pressure if you start squeezing on your muscles and breathing deeply and heavily? It would increase blood pressure. It's going to increase your blood pressure because you're getting more venous return, which ultimately increases cardiac output and increases blood pressure. Okay, good. So what organ regulates or maintains cardiac output? You guys know this. It's your heart, exactly, good. But there are other factors at play, though, because you have your kidneys and your blood vessels, too. So this one's talking about the heart. So cardiac output, we know that's what your heart's doing, okay? But what about resistance? Which organ's doing that? Your blood vessels. Good, exactly. So there's one more that's not in here, you guys, that I didn't draw yet. That's your kidneys. And the way your kidneys maintain blood pressure is up here on the venous return end, because your kidneys maintain blood volume. And if you increase blood volume, you're going to increase venous return. If you increase venous return, you ultimately increase cardiac output. Okay? So here's the thing then, you guys, is that if you change one variable, it can be compensated by the other. So for instance, what if your heart rate slowed down? What can your other organs do to get your blood pressure up? Well, your blood vessels can constrict, and your kidneys can help retain more water, right? Or what if all of a sudden your blood vessels dilated? What could your heart do to keep your blood pressure up? Say it again. Pump harder, right? Harder and faster, right? So you can basically just increase cardiac output to keep your blood pressure up. If your blood vessels dilated and this end dropped out, your heart could speed up to keep your blood pressure up. Now, on the tests, they're going to be kind of more straightforward questions like 1-to-1. You know what I mean? Like if this, then this. It won't be a complex question like you have a patient with anaphylactic shock whose blood vessels have vasodilated and they also have acute renal failure. What's their blood pressure? Don't worry about that. That's too complicated, and actually that would require more data anyways and more ways to measure. So it'll be more simple like if you increase cardiac output, what happens to blood pressure? Increases. If you decrease resistance through vasodilation, what happens to blood pressure? No, decreases. Yeah. You decrease resistance, decrease blood pressure. Okay. So know those rules, you guys. That's really important moving forward. Okay. Cool. So with cardiac output, you guys, we say that stroke volume times heart rate. Your normal cardiac output's like 5 to 5.5 liters per minute, right, at rest. And it's determined by venous return and neural and hormonal controls. The neural and hormonal controls that determine cardiac output would like affect contractility or heart rate. We said that, remember, the positive inotropic agents that increase contractility could increase cardiac output. So an example of a positive inotropic agent was glucagon, epinephrine, thyroxine. All those would increase stroke volume, which would increase cardiac output. Okay? And so then resting heart rate's maintained by what's called the cardioinhibitory center, which is your parasympathetic nervous system mediated by the vagus nerves. And so your vagus nerves, we talked about that, they keep your heart rate down during rest, right? And so then stroke volume is controlled by venous return or EDV. Okay, so what this flow chart here shows you guys is just kind of a nice summary of these kind of effects here. And things we've kind of already talked about already as well. So let's think about this, you guys. If you start to exercise, what are you going to start doing more of if you're exercising? You're going to start breathing more heavily, and you're going to start moving your muscles. What does both of that do to venous return? Increases venous return. You got it, right? Now, if you're exercising, you're sympathetically active, and your sympathetic nerves can cause venoconstriction, right? If you increase venous return, that increases ventricular end diastolic volume or filling, right? If you guys remember, we said that when you increase end diastolic volume, that increases stroke volume in two ways. Not only are you filling the ventricle with more blood, but the ventricles will contract more strongly. That was the Frank-Starling law, if you guys remember that. So we said that ventricular end diastolic volume rises and increases with contractility because basically through stretch of the muscle, you get optimal tension, length-tension relationship with the sarcomeres. That was the Frank-Starling law. If you guys forgot that, make sure you guys go back and review that too. Okay? So that's going to increase stroke volume. Now, stroke volume, when that rises, is going to increase cardiac output. So just on the venous return end, presumably that would increase cardiac output. Now, you wouldn't even necessarily need to be exercising either. Like, what if you were just sitting here breathing heavy, like going, that presumably would increase blood return back to your heart, and that should also increase cardiac output. However, would that automatically increase your blood pressure, though? Like, is your heart the only thing that can change your blood pressure? No. Remember, you also have your blood vessels and your kidneys that are involved too. So it's hard to make these predictions about what's going to happen when you make these changes. But we can say generally, these things will happen. Okay? So what about on the side of your nervous system? Well, when you're exercising, you're less parasympathetically active, which means your heart rate's going to go up at least to 100, right? Where it's an intrinsic firing rate. But if you're sympathetically active and you start releasing epinephrine or adrenaline in your bloodstream, that's going to increase your heart rate even beyond that, right? Now, if the increased heart rate, that's also going to increase cardiac output because that's in the equation of cardiac output, okay? So it's on both ends. Your nervous system, which can modulate heart rate, and your venous return, which can modulate stroke volume, both can increase cardiac output here. Now, make sure you guys have this down like the back of your hand because all of this is important for knowing about shock. So when you guys take pathophysiology, probably your next class, I wouldn't wait too long because you don't want to forget this stuff. You'll learn about shock, and the ways that your body compensates for shock are exactly this. Like just you're just basically trying to do all these things to reverse shock. So make sure you guys have this down for sure.